Good afternoon, everyone. I'm going to get this webinar started because we have a lot of exciting material and we are recording it, so we will be sharing the recording and slides. Hello and welcome. I'm Nora Dunlap, Program Officer for the MAT Access Point Project and the Center. Thank you so much for joining us today. The MAT Access Point Project, and I have this same beginning for every one of our TA webinars, but the MAT Access Point Project aims to create a network of organizations throughout California to address the opioid crisis by supporting prevention, education, stigma reduction, treatment, and recovery services with people with opioid use disorder and substance use disorder, and especially by increasing access to medication-assisted treatment. Throughout the project period, we are offering several technical assistance webinars for partners to access as resources. And again, this entire webinar is being recorded, and we will share it along with the slides in the online portal under the resource page, and also on the MAT Access Point website under the webinar page. If you have any questions at any time during the webinar, please feel free to use the chat button found at the bottom of the webinar screen. We'll sort through them and we'll address as many as possible. But it's truly a privilege for the Center and the MAT Access Point Project specifically to sponsor this webinar, providing an overview of medication-assisted treatment, including education on the fundamentals of treating opioid use disorder in primary care settings. And with that, I want to introduce and welcome Grace Katie Bell. She is a nurse consultant with Telewell Indian Health MAT Project, offering technical assistance, mentoring, and training throughout California for California Indian Health clinics as they develop MAT programs. She is also part of the UCLA Hub and Spoke Learning Collaborative and participates in the UCLA ISAP Tribal Project ECHO for Indian Health primary care clinics throughout California. A board-certified in addiction RN, Ms. Bell has been working with the medication buprenorphine naloxone, in parentheses Suboxone, since 2001 phase 3 NIDA clinical trial. And over the years, she has been developing and launching programs of care for patients with opioid use disorders in multiple settings, such as inpatient residential at Betty Ford Center, an urban methadone clinic, a Department of Veteran Affairs behavioral health clinic, and now primary care FQHCs and California tribal and urban Indian primary care clinics. She is also an MAT nurse consultant for Center for Care Innovations Addiction Treatment Starts Here, primary care, along with Telewell Indian Health MAT Project supporting tribal opioid response efforts in California. So thank you again so much for joining us. Katie, welcome, and I'm going to turn it over to you.
Oh, thank you, Nora. Hi, everyone. Can you hear me really well?
Yes.
Okay, so we're going to get started. We have a lot of ground to cover. I'm so grateful for this opportunity to talk about treating people who suffer from opiate use disorder with medication-assisted treatment and the whole person approach to care. So that's just my other thing. I have nothing to disclose in terms of any corporate connections. I always begin with the spirit of our work. This is a context of how we provide care for our patients. Whole person healing occurs in the context of one's identity and culture. And since I work with tribal MAT, this is very specific to the identified needs in the tribal communities, the urban Indian health communities. We begin with respect and a commitment to best practices. We understand our patients, all the social determinants of health that come along with them, and we cultivate, reinforce, and develop the language of dignity. Treating the stigma injury is an essential part of our work, and we'll talk about that quite a bit in a little bit. And recovery is healthy autonomy. That is one of the core values, as we help our patients discover their own healthy choices and honor their ability to do so. And intersectionality is understanding the disparities and injustices in healthcare. A big part of our work is to include everybody and identify their particular challenges. Real quickly, we are in the middle of the response to COVID-19. The clinics throughout the state had to shift very quickly to providing medication-assisted treatment care almost entirely via telephone, Zoom, telemedicine. The DEA supported this process immediately as soon as we went shelter in place. The DEA adjusted some of the rules and regulations around providing medication-assisted treatment so that it could be done effectively via telephone. There are Zoom groups in most of the clinics. The behavioral health is in. There's been actually, with many clinics that I'm connected with, a very beautiful pivot to telehealth care. We also have to include understanding of the special needs of our vulnerable patient population, with educating them about social distancing, especially when sharing drugs or syringes, really ensuring that Narcan distribution continues and increases, and to work closely with the California Bridge program where patients can receive care in emergency departments. But we're going to really, that's kind of something of concern, because we don't want to send our patients to the ERs because of the virus, but that is a backup plan for patients who maybe run out of their prescribed buprenorphine. The increased stress of disrupted lives is a huge issue. Isolation, unhealthy home environments can increase risk of relapse. So a lot of environments have drug use going on, and many other family dysfunctions. Our patients require more support and increased access to care. So if we're doing it via telephone, we really have to call more frequently to make sure our patients are getting all their needs met. So intersectionality, I'm going to show a kind of a visual on this, but this is really important that we understand where intersectionality and the needs of communities of color are very specifically addressed or undertreated. And so we have to keep our eyes open to the health disparities. Black communities have had chronic pain undertreated. Historically, that's a key aspect of our conversation. The historical trauma, the institutionalized racism directed at descendants of enslaved people and indigenous people. Methadone clinics were rolled out in the 70s in the inner city Black communities when there was a time of disruption, and it was, the question was, how do we sedate? So we have historically a very mixed political story that's tied to injustices, and it's important for us to understand the background and to stay committed to justice every step of the way. The LGBT community is reluctant to seek medical care for fear of stigma and prejudice, so our outreach must be effective. Our patients in the LGBT community need to have a clear understanding of safety so they can come in and get care. The Latino community's access to care is impacted by no insurance, with jobs, fear of deportation or exposure to immigration authorities. And elders and seniors are over-medicated, often over-medicated, and also undertreated. So those are just a few of the basic disparities that we have to consider in the intersectionality. Here is a really kind of a useful and probably familiar to many of you, the intersecting axes of privilege, domination, and oppression. This really helps clarify as for those of us that are providing care to communities of color, underserved communities, that things are not equal, and it's our job as providers of care to understand uh, how intersecting accesses impact our patients and our communities. Um, I love this particular image because it really clarifies what most of our patients are struggling with. Even less than 1 in 10 people with substance use disorder receive treatment. This is a really devastating fact, driven by health disparities and driven by overt um, stigma, which we'll talk about in a little bit. So our job is to get those doors open and welcome people who are struggling with opiate use disorder and other substance use disorders, and provide care and help them get pointed in a direction that they want. Quick guide to acronyms and terms. I'm not sure the people in the audience if this is familiar to you or not, but bear with me. So the term MAT, medication assisted treatment, also people say MAT, sometimes I say MAT, it's kind of interchangeable, can also be identified as medications for addiction treatment and also medications for opiate use disorder. You're going to see all of these, they basically mean the same thing. This term came out a little over 4 years ago as a way to create a more open appreciation for treating addictions with medications. We have been really informed for many years by the 12-step community's commitment to what's considered to be abstinence. We still struggle with this, but we've made a lot of progress. Opiate use disorder is the term that we use to describe opiate use disorder. We're going to talk a little bit about the difference between dependence and opiate use disorder. We'll break that down a little bit in a minute. Stigma is the barrier to care, communicated by language, judgmental attitude, and because of this judgment, decrease in quality of care. So stigma is the biggest barrier, and there's lots of conversations and education around it, and it's continues to be an uphill battle and a reason people don't get help. We use the word diversion to describe trading, sharing, stealing, selling, buying illegal or prescribed controlled medications and substances. Buprenorphine, Suboxone is frequently diverted. And that diversion is driven by multiple things, but one of the main reasons that diversion continues around buprenorphine is that we do not yet have access to care throughout our communities. Misuse replaces the word abuse, which means taking more than prescribed, using non-prescribed opioids, including injectable heroin. Common terms, harm reduction. We basically focus on the people who continue to use drugs rather than on the prevention. Harm reduction comes naturally to medicine. So harm reduction is more of a treatment term, and because in medicine we're always going, how can we keep this person as stable as we can, as safe as we can, no matter what the diagnosis is. So it's understood thoroughly in primary cares and medical settings. Abstinence-directed substance use treatment, which is focused on abstinence from all drugs and alcohol. The term in the 12-step informed world is clean and sober, which does not include tobacco or caffeine. And the level of care is we're using the American Society of Addiction Medicine criteria for assessing whole person needs and best level of care for stabilization. So when we talk about level of care, we're actually referring to a way that we measure, identify, and refer to treatment. Motivational interviewing, what is it? Well, motivational interviewing is our language. That's a therapeutic interventional language where we focus on the patient at where they are in terms of readiness for change. We identify that readiness, we meet them where they're at. We explore ambivalence and discuss discrepancies, and we support autonomy. It's a beautiful thing if you're working in the world of treatment. MAT, I really encourage you to have a good, thorough training in motivational interviewing. It's a powerful approach and very, very useful to have. It is our basic language of addiction treatment, and it is an essential piece of the conversation. One of the ways it was developed by Dr. Miller and Dr. Rolnick, dancing rather than wrestling is a good way to describe it. We meet our patients where they are. We dance with them to help them find change, to understand their own motivation, and it's a beautiful, respectful language. And we meet our patients where they are, but we do not leave them there. One of my favorite quotes about motivational interviewing. Opioid dependence plus behaviors. Opiate use disorder equals opiate use disorder. So sometimes there's confusion. Opioid dependence is physiologic. Includes tolerance, which causes a need to increase quantity to sustain effect. And it includes withdrawal symptoms when opioid is stopped. Often the language around people who are being treated for chronic pain with long-term opioid therapy identifies them as addicted or addicts, and maybe there's absolutely no behavior presented by these individuals. They take the medications as prescribed. We do understand that they have opioid dependence. Another place where we really need to change using the term, addicted is with babies. When babies are born with opioid dependence, they are not addicted. They're not born addicts. And then we move into understanding that addictive behaviors involve misuse, such as taking more than prescribed or continued compulsive use in the face of increasing consequences to health and wellness. The behaviors often include diversion and relapse driven by craving and triggers. So a clear distinction when meeting our patients is to really understand all these elements and make the correct diagnosis. Now I'm going to shift a little bit to the direct experience of people who have opiate use disorder, and of the intensity of their experience helps us understand the whole suffering of our patients. So this is a quote from Dr. Corey Waller, and it's a very well-known quote right now. We need three things to survive besides oxygen: food, water, and dopamine. If you deprive study subjects of water for 3 days, then put them in a functional MRI and place water on their lips, the relative size of the craving is like a baseball. Do the same with food, and it is like a basketball. Then take someone with an addiction to opioids up to 1 year after their last use and talk about OxyContin while they're in a functional MRI, and the relative size of that craving is the size of the baseball field. So there's the visual on craving. The little baseball over here is water after 3 days. The basketball is food. And then we have the intense desire, craving in the brain, measurable and studied in the brain for craving. So it's important that we understand our patients when they just can't stop on their own. Our patients need care. The other part of this human suffering, the direct experience of our patients, is the experience of opioid withdrawal. We measure this when we treat our patients with buprenorphine, Suboxone, and it's called the CAWS, the Clinical Opiate Withdrawal Scale, and it's very intense. Anyone who has experienced it or been with someone who is suffering, it would make sense to make it stop, which is why there's constant resumption of use, or what we call relapse. So it's a high heart rate, dilated pupils, hot and cold sweats, body aches, especially in the back and legs, runny nose, intense intestinal distress, severe anxiety and agitation, severe restlessness, tremors, yawning goose flesh. We measure these so that we can safely relieve their withdrawal. So if you combine a baseball field size craving with the worst flu you've ever had, and I'm not talking about coronavirus, but this is how they've described it over the years, we would understand why it is difficult for our patients to stop using. The human suffering, it also includes all the people around our patients. Overdose deaths are about 114 every day. I read an article yesterday that said in 2018 it was 185 patients a day. So that leaves many orphan children, grandparents raising families. They're called kinship families now. Babies born with opioid dependence. Notice that we didn't say addicted. Actually, babies born with opiate dependence, it's called neonatal abstinence syndrome. Children in foster care, our agencies are overwhelmed. Our jails, our CPS, our emergency services cannot meet the demand of this particular epidemic effectively in most places. Heartbroken families and communities. At this point, most of us know about, heard about a relative or family member or friends, someone in the community who has died of an overdose. And the losses are very sudden, extremely painful. Incarceration, many of our young folks end up incarcerated due to the drug-related criminal activity, and often they have to live with felonies, which makes it really hard for them once sober and focused on rebuilding their lives to get good jobs. Hopefully we can change this. The medical challenges, Hep C, HIV, endocarditis, abscesses, cellulitis. It's really hard on the lifestyle, extremely hard on the body. So why is there a focus on trauma care in MAT? So let's think for a minute. A full agonist opioid is a very numbing medication. It numbs emotional and psychological and physical pain. The numbing characteristics can turn off the symptoms of trauma. The relief which comes from opioid use and misuse is often the beginning of addiction. So we're looking at the first experience around a full agonist opioid is some kind of relief. If it's physical pain, it's to relieve the pain. And it's a kind of an obvious drug of choice for our patients who have trauma symptoms. When a patient seeks help for opiate use disorder, we must help them discover and heal the root cause, which is often childhood and or adult trauma. Many MAT programs screen for childhood trauma with the Adverse Childhood Experiences screen, and the ACEs scores in MAT programs are often very high. There's a push out there now. There's more use, the introduction of the ACEs screening in primary cares, which is very exciting because we begin to understand that choosing an opioid may be about choosing relief for pain. Cultivating resilience is if you're looking at trauma, you're going to be looking right at resilience. If that patient has made their way into our program, they are resilient people, and our job is to identify that, celebrate it, cultivate it, and really help our patients have an understanding of their own strengths, which supports that healthy autonomy. Recovery for many of our patients, once stabilized, will involve repairing mistakes, rebuilding a meaningful sense of direction, family, relationships, education, and jobs. All of that work is built around resilience. So the MAT team with behavioral health, with the nurses, with the providers, with the substance use counselors, with all the team, we identify trauma when we screen the intake using the ACEs and other questions. And then we go into really helping our patients experience directly their own resilience. Very important. So the return of the felt experience, this is something that a lot of people don't know and understand about buprenorphine, Suboxone. So when our patients go from the full agonist opioids, whether it's heroin, fentanyl, pain pills, any of those are all full agonists, and they switch to buprenorphine to turn off the craving, to turn off the withdrawal. Buprenorphine is a partial agonist. We'll talk about that also a little more thoroughly. There will be a return of emotions and sensations. This is a crucial piece of information. For our patients have described it as an emotional thawing out or a tingling to life. This is important to remember in the context of sensitivity to trauma and other untreated behavioral health diagnoses. The return of painful emotions and sensations can trigger relapse. So we need to be aware of this. We need to educate our patients. You're not going to be craving. Your brain in a lot of ways is going to feel normal with buprenorphine, Suboxone, but you may be feeling a lot more. And we need to make sure that your care includes understanding that and supporting you through that. I've had patients say that they're crying at movies and enjoying the laughter of their babies in ways that they couldn't when they were using full agonist. So it's full of possibilities, but it must be understood and addressed. Otherwise, they're going to say, well, this thing doesn't work for me. I'm miserable. So this is just real quickly, we use phrases like addiction. Addiction is actually a word that we use in medicine. It's a chronic progressive relapse disease. And then we go across the hall into behavioral health, and it's identified as a substance use disorder. And it's in the DSM-5, measured on a continuum of mild to moderate to severe, very crucial way of identifying severity and being able to provide the appropriate level of care. And even though there's usually what we used to call polysubstance use, we actually identify each co-occurring use disorder, opioid use disorder, alcohol use disorder, stimulant use disorder. Those are very common co-occurring use disorders. Discover simple ways to change language, teach trauma sensitivity and empathy. This is where the rubber hits the road. If our patients don't feel safe, they do not return to us. So stigma in our thinking, attitude, and our language, shaped by thinking, a bias and a perception. I just read an article yesterday about the persistent stigma that is really a challenge in communities and becomes internalized. It's still alive and well in medical settings where patients go for care. Substance users are bad and immoral rather than ill with a chronic condition requiring care and treatment. And this also often includes the chronic conditions of mental health disorders. Stigma is communicated often very subtly by tone, interpersonal attitude, body language, and of course by words. Stigma becomes internalized as a person seeking help. The person views themselves as bad, as dirty, as weak, which fuels the shame of stigma. We stopped using the word abuse, as in substance abuse is no longer part of the medical lexicon. We use the word misuse instead, or even use, opiate users. We've gotten rid of the use of the word addict. We use person with substance use disorder, or people who inject drugs in some situations, opioid users. This term is, we hear it in everywhere, but we hear it in our 12-step culture, where someone would raise their hand and say, I'm Katie, I'm an addict. That is a slightly different way of using the word addict. We'll see if it changes in the 12-step culture, but right now it's a way of identifying that they're in the recovery process. So we're not going to go in there and change it. Drug seeking can be, or med seeking, or even frequent flyer, which is a term used in ERs, can be reframed as relief seeking. Focus on the person rather than the behavior. So if a competent nurse in the ER meets with a person, rather than saying they're med seeking, they will explore with the patient the relief that they are seeking. And it may be for the cravings, the size of a baseball field, or maybe they're seeking relief for withdrawal. This really is a good way to reframe it if we're treating our patients with opiate use disorder. Nodding out is a street term that is used to describe sedation caused by too many opioids, or combining opioids with other sedating drugs. I heard this term used in the clinic that I was in about someone who was taking a nap in the waiting room. It can be very stigmatizing. It's not necessary. Stigma itself is a secondary injury of substance use and can require treatment. When we talk about stigma, we tend to be a little bit too general. But as an addictions nurse, I have met with thousands of people who have personally and directly endured stigma. And I have identified it as a secondary injury that has caused a lot of unnecessary suffering and death. So when we meet with a patient, it's important that we acknowledge the injury caused by stigma, that going into the ER has been in the past, or talking to your doctor openly about your drug and alcohol use has been impossible in their minds. It's a secret that will not be disclosed in a place where there would be help. So the primary symptoms are distrust of the medical world, especially emergency departments, and feelings of shame, and really being dishonest to deny that there's a problem, because to admit to it would feel unsafe to them. Not treated, the person internalizes the shame and the low self-worth caused by stigma. This is really important to understand. Think of a person who has maybe been seeking help for 20 years as they struggle with their substance use disorder. I've had patients that have told me they would rather die than go to the ER. And that's a terrible fact that we have to change. It's up to us. So what is the treatment? It's higher doses of the language of dignity. Empathy and compassion should be just part of who we are from the very first moment of contact with our patients. Kindness, respect, listening is a really beautiful way to begin to heal the stigma injury that our patients present when they come to us for help. In medicine, we do not refer to lab results as clean or dirty. I've never sat with a doctor and had my blood work reviewed where the doctor said, well, your A1C is dirty. That would never happen. So we use medical language at all times to support the dignity of our patients. We can say positive, it's positive for buprenorphine, negative for opioids, or it's consistent or inconsistent, meaning that it meets the standard or doesn't meet the standard of the program. This is probably one of the most common, in a lot of ways, the most egregious misuse of terminology around patient care. It's a lab result. Patients want help. So the solution, we now know about the severity of craving, the intensity of craving, the unbearable experience of withdrawal. We understand how the impact of stigma is a barrier. Now we're going to look into how we change this. Am I doing on time? Doing okay. So, so there is no wrong door. Addiction treatment starts here, is the way that we have to perceive and operate in terms of the opioid epidemic and getting patients in through whatever door they knock on. So we open the doors, we develop programs, we do community outreach, education, and understand that any door they open is the right door for them. And we keep barriers to a minimum. The last few years has been transforming for the medical community and the agencies that worked together a few years ago. We would gather, and we didn't have any MAT programs in our town. And now there are multiple ways to access medication-assisted treatment for our community, and that has been built with coalitions and teamwork. So Suboxone, buprenorphine, there's some characteristics that make this a very good and very safe and effective treatment. It is a partial agonist opioid. It has a high affinity for receptors. I don't know if there's any providers in the room, but this is going to be kind of layman's understanding. It's low activating. It has a ceiling effect, and it's very long acting. It has about a 37-hour half-life. It relieves craving, relieves withdrawal, and there's no significant euphoria. This is not where a person would turn to experience euphoria. This is a medication that relieves the overt symptoms of opiate use disorder. It normalizes the brain. One of the most common things I've heard from my patients, no matter where we were and whatever setting, they would say, I feel normal. And that's a beautiful thing for somebody to report who has lived a chaotic life around drug use. Combined with naloxone. So buprenorphine is combined with naloxone, and the brand name is Suboxone. So even though Suboxone is the common term and it's universally used, it really is buprenorphine. Naloxone as generic and appropriate way to talk about it. It's taken through the skin, sublingually or transdermal. Also subcutaneous injectable, which is called Sublocade. That's a injection every 30 days. And there's also Probufene, which is a 6-month implant. Another one of the medications of MAT is Narcan, naloxone. It's an opioid antagonist. It's an opioid overdose reversal treatment. And we're committed in all of our agencies, all of our clinics are committed to getting Narcan basically in the hands of everybody. Narcan in every purse, that's my motto, unless you don't have a purse. But anyway, we have made it easy to access. And the Department of Healthcare Services has had a very strong, direct way of getting Narcan and how to use it to as many people in our communities as possible. XR naltrexone, often commonly known as Vivitrol, is one of our other medications. Minimal relief of opioid cravings. It's a long-acting antagonist, and it blocks the effect of opioids. Not as effective with managing cravings, but often it is the best option for a patient who may not be able to access treatment easily. It will protect them. And because it does relieve alcohol cravings, often when we have a patient with co-occurring alcohol use disorder with their opioid use disorder, we'll consider offering Vivitrol. So there's the Narcan, there's a picture. I'm not advertising, as you know, but some people wonder what it looks like. There's a Suboxone. This is the most common way that buprenorphine is prescribed, with the sublingual strips. Vivitrol is not a controlled medication, and also accessible through special grants and programs. So what is an X waiver and why is it important? Real briefly, I just wanted to cover this because it's common in our everyday language when we talk about providers to say, well, are they waivered? Do they have a waiver? When are they going to get their waiver? And it's not always understood what exactly that is. So the Drug Addiction Treatment Act of 2000 made some changes around whether a physician could treat opioid use disorder in the office. They developed something called opioid outpatient buprenorphine, OBOT. So office-based addiction treatment, office-based opioid treatment is what OBOT stands for. So this was really a big leap into change in terms of providing care. Physicians take an 8-hour training to get their DEA waiver, to qualify to be able to apply for their DEA waiver. The reason we call it an X waiver is that once waivered, that provider has an X in front of their DEA number, so that pharmacies and the system throughout can identify this as a waivered provider. In 2018, the Support Act allows mid-level providers such as physicians and assistants, nurse practitioners to also become X-waivered. The requirement for training is 24 hours, and if there are any PAs and nurse practitioners out there, I welcome you. I'm glad you can be part of this wonderful work. An X-waivered provider can have 30 buprenorphine patients in the first year. I just was talking to somebody this morning, so now it can go up to 100 patients, 275 patients for X-waivered providers who have been prescribing for a longer amount of time. We really need more X-waivered providers. It's really a significant shortage in some of our communities. I want to talk briefly about fentanyl. First wave of the opioid epidemic was the overprescribing of opioid pain meds. There was a big push to change that. CDC put out some new guidelines, which turned out to be maybe a little bit too harsh, and we ended up having what we call pain orphans, where they couldn't have their pain well managed because of their history of being prescribed high doses of opioids. The second wave was heroin, and third wave is fentanyl, which is still really hitting our California communities pretty hard. It is 50 to 100 times more potent than morphine. It's deadly. It's sold through illegal drug markets, and the fentanyl-related overdoses are on the rise in California. So often it's mixed with the stimulants, cocaine and methamphetamine. So the clinics often will, if there's a patient who is consistently positive in their urine drug screen for methamphetamine use, we will also have that sample tested for any fentanyl that the patient may not know about. Methamphetamines, also an epidemic. More and more our patients with opiate use disorder also come in with a co-occurring severe methamphetamine use disorder. We're really going to be shifting into more focus on addressing this in coming years through our grants. There's a important element of care that we need to develop and roll out in our programs. The consequences of methamphetamine use are terrible for the individual. We've all seen pictures of people who have used methamphetamines for years, and the damage is pretty horrific. It is also the most difficult to treat medically. The withdrawal is difficult and can be a prolonged period of depression and loss of enjoyment in life. And our work is cut out for us. We have a lot of work to do. The methamphetamine epidemic is also very closely tied to the ever-increasing number of people experiencing homelessness. It is considered by some people who have spoken to me about this a way to stay awake, to protect their belongings, a way to stay awake when in the streets, to stay safe, to endure cold and deprivation and hunger. This has been described pretty graphically to me by my patients as to why they choose to use methamphetamines when they are without a home. Lots of work to do here. Contingency management is a project that we were rolling out before COVID-19, which we put that on the back burner. We really need to understand and treat the withdrawal and the prolonged period of low dopamine and depression. Solution: recovery and wellness, whole person care. Case management is often key. Does the patient have a home? Do they have a safe home? Do they have income? Do they have a vehicle? Do they have children that have unmet needs? Behavioral health, we really need to know our patients' psychiatric history and make sure those needs are met, medical needs. So an MAT program in primary care, we wrap our multidisciplinary team arms around our patient. Recovery support, do they need referral to a higher level of care? We partner with our patients, we focus on their resilience, the return to values, understanding that sensitivity is often, there's often a healer and an artist hidden in there that we want to coax out and celebrate. Helping with life directions. Do you need to get a job? Do you want to enroll in school? And the very difficult work of restoring relationships with, especially with our families and our loved ones. This is all part, you can't just throw a medication at the patient and expect them to accomplish all this. So this is part of our partnership. And it's a beautiful gift to be able to share in that journey. Real quickly, a basic pathway of care for our opiate use disorder patients. In primary care, we focus on stabilization and monitoring and recovery tools. So there's screening and referral. There's the assessment, which should be comprehensive. We begin with medical stabilization. So if a patient walks in and they are exhibiting those symptoms of withdrawal that we reviewed a few minutes ago, we're going to get them seen by the provider and get them started on the medication right away. We'll take care of the paperwork once they're comfortable. So we can really limit. Once a patient walks in, our goal is to get them comfortable and to begin the stabilization recovery process. The right dose of medication is part of the care, the handoff to the behavioral health and the substance use team. It's always helpful to have a treatment agreement, which includes informed consent, and a treatment plan. And we are just providing education and support every step of the way. So, so here's some staff training recommendations and links. There's Dr. Corey Waller, Addiction 101 is excellent YouTube. He really describes the neurobiology of addiction, expert training. This is also very useful. Here's motivational interviewing, and core competencies are essential. As you can see, the California MAT Nurses Weekly Forum is in the past. Also, staff recommendations. Here, there's all kinds of things that you can plug into. There's a smartphone app called Narcan Now, free app, an excellent training video. Often we'll go over that with our patients, show them how to pull that up when we give them their first RX for Narcan. And here's some more resources. And I think we have some time for, I'll go back to my sharing the screen.
And yes, Katie, there's been a couple questions. I've been looking through the chat. The first one is, can you just confirm that X waiver patient limit now has increased or changed to 100 in that first year? It sounds like some of the providers have experience with that, but just a confirmation.
Well, you know, I just got a text this morning, and maybe that's Danny that's asking the question. And he's found on SAMHSA, apply for, yes. So he found it, the link on the SAMHSA, and I will make that available if anybody needs that after
Perfect.
group. So apparently, they allow newly waivered prescribers to increase to 100, and that has been confirmed on the SAMHSA website. Other questions?
Another question was, do the MAT medications have negative side effects?
Yes. So with buprenorphine, the side effects you're gonna look for are the common ones are nausea early in the first few days. Maybe there's a headache, dry mouth, constipation is a very common side effect, as it is with the other opioids. Persistent sweats for some patients are also pretty common. But if a patient is on the right dose, the goal is that they have no cravings, no withdrawal, and no or minimal side effects. So it's pretty comfortable. Vivitrol is naltrexone. There needs to be monitoring of liver function tests to make sure that their livers are safe with that. When Narcan is used, it's used so briefly that the outcome of saving a life overrides. The side effect is that patient comes back to life. Not aware of any serious side effects with Narcan. What else do we have in questions?
Another question came in, is there a list of X-waivered providers in Southern California, or really anywhere? Is there a list that people can access for X-waivered providers?
Yes. Wonderful question. So the SAMHSA, and it's interesting, it's called Substance Abuse Mental Health Services. And we all know and have known for a while that we don't use that term substance abuse. But anyway, rest my case. They have something called a buprenorphine locator. They also have a treatment locator. So you can go in there and say buprenorphine locator, and then it will give you a map of the country, and will ask you to click the state or put in the zip code, and you will see all of the waivered providers in that zip code. This is also true for treatment providers. It's a really great tool.
Awesome. Thank you, Katie. And then another question, so really appreciate connecting stigma to causing injury. To what degree does stigma show up among prevention and or treatment providers? How does this show up in training?
Is the question, how do we respond to it in training? We
Connie,
respond to it.
If you're able to clarify a little bit, I'm going to ask the person who asked just to make sure that I answer it or ask it correctly. Is the question more around how to respond to stigma in training? And then while Connie is doing that, another question is, how effective is Narcan in regards to fentanyl overdose?
Narcan often requires definitely requires more than one administration normally, because of the intensity of the impact on the receptors. So we all, part of the training in Narcan is that if the first dose doesn't bring that patient back to consciousness, we're going to give a second and possibly a third. That is very common in fentanyl overdose. And if anyone else wants to add their thoughts on that, I'd love to hear it. Okay.
Another question, for a patient taking Sublocade for 6 months and experiencing cravings 2 weeks after the injection, would you administer a second dose sooner or add supplemental buprenorphine or something else?
Well, this is a really common question. Hi, Janelle. So we're finding that some patients have quite a bit of breakthrough withdrawal with Sublocade, and there's different ways of responding to that. Often there's a supplemental dose in the first weeks, maybe even the months, where there's a sublingual dose added to it. But if this persists after 3 months of Sublocade, I would really recommend that this particular delivery of buprenorphine be reassessed. Some patients are really good to go on almost immediately, and others struggle with what they describe as breakthrough cravings or withdrawal. Does that answer your question?
I think so. We'll see if it comes back up in the chat.
I'm not going to give any medical advice, because that's
Yes.
practice. I do have some answers, and Janelle, if you want to reach out to me, you know where to find me. We can explore it. Okay. Anyone else?
Do you know, is the Hub and Spoke program currently active in the Inland Empire?
Oh, yeah. Yes, it is. The Hub and Spoke program has been around for 2 years. The goal was to open the door to care for at least 20,000 patients. We far exceeded that. In the Inland Empire, there are multiple spokes and multiple hubs. So you can look up the more pertinent information to that area in the Hub and Spoke California MAT expansion project, and pull up the Hub and Spoke page.
Oh, and Connie was able to re-ask the stigma question. So the question is stigma prevention a part of provider training? And if so, how?
Well, there's many ways. Today was stigma prevention or training around that. So it's really a big part of all the programs. I know that it's addressed in the waiver, the ex-waiver process. So it's really, this is kind of a broad question, Connie, but there's lots of stigma training for providers. Often we'll encounter a provider who will say, I don't want to use an opioid to treat an opioid use disorder. That's kind of a beginning concept for some of our providers. So the goal is to educate them, and stigma prevention is not as big as it needs to be. So maybe you can introduce an approach to that. So that was kind of vague, but it's out there. If you feel like the providers need stigma training, there are resources all over to access that. You could go to the Boston Medical Center. They have a tremendous amount of materials on all things around OBOT and MAT and stigma and creating safety for our patients. And you can give me send me an email and I'll put you in touch with other opportunities for stigma prevention.
And Katie, I do see that it's 1 o'clock. Do you have time for about 1 or 2 more questions, or should we just ask for those to be coming in via email?
Yeah, I have to go to my next round. I would love to please share my email address with any of the participants if you feel that you didn't get questions answered, or if you want to argue with me. I always love that. And it's part of the learning process to kind of explore different approaches. And I so appreciate all who have attended here, and I hope that you have learned something.
Thank you so much, Katie. We are so appreciative of your time and this presentation.
Right.
Yeah. We are sharing the recording and the slides on the mataccesspoints.org website. And if your question didn't get answered and you want to connect with Katie, please send us an email at the center or through mataccesspoints@shfcenter.org, and we'll connect you to her. Thank you, everyone. Have a wonderful day.